Hello and welcome to our lung cancer awareness webinar. I'm Jamie Callie with RWJBarnabas Health Medical Group. Today I am joined by Dr. Lackey, Dr. Patel, and Dr. Sesti. We're going to be talking about lung cancer risk factors, signs and treatments, and some advanced treatment options. I want to thank you all for joining me today and for taking some time out of your very busy schedules to chat about lung cancer. I'm going to get started with the first question. That is for you, Dr. Sesti. Welcome. Let's talk about what is lung cancer, common risk factors, and signs and symptoms that we can all be looking for in ourselves, where we might say, hey, I'm experiencing this, probably a good time to go see my provider.
Sure. So thank you very much for inviting me to speak at the webinar today. My name is Joanna Sesti. I'm the Chief of Thoracic Surgery at Barnabas Medical Center. And I'm very happy that we're having this webinar, considering that November is Lung Cancer Awareness Month. So lung cancer is essentially cancer of the lung. There are different types of lung cancer. Some are more aggressive than others. As far as the risk factors for lung cancer, smoking is essentially the #1 risk factor for lung cancer. It's responsible for about 80% of all lung cancer diagnoses. And while heavy smokers are at the highest risk, any amount of smoking really can predispose you to lung cancer. Additionally, even if you don't personally smoke, but if you have exposure to secondhand smoke, if it's regularly, that can also increase your risk of lung cancer. There are other risk factors that are not as commonly associated, but have been associated with lung cancer. For example, radon gas exposure. Radon is a gas that's naturally occurring in the environment. There are test kits that people can buy to test their homes for radon, but it's really not that common. Finally, but in addition, asbestos exposure, I think that has gotten a lot of media attention because of its link to a specific type of cancer of the chest called mesothelioma. Most buildings, newer buildings, don't have asbestos included in the manufacturing anymore, but certainly individuals who work in construction, where they're involved in renovations of older buildings, can have asbestos exposure. Some people claim that poor air quality can predispose you to lung cancer. Obviously, we all live in the Northeast. We're all in big cities. Not much we can do about that. And finally, it's either personally having a history of lung cancer can predispose you to forming new lung cancers, or if you have a strong family history, that is also considered to be a risk factor for lung cancer.
Excellent. So smoking, obviously, I think you said 80% puts you at an 80% risk. November, we're also talking about helping individuals quit smoking and get on the path to getting healthy lungs. If someone out there is watching this is a smoker, if they were to watch this video and quit smoking today, what does that do to change their sort of outcomes for either? Does it lower their potential for risk cancer? Does it help if they possibly already have lung cancer? Is it reducing? Is it helping them get healthy again? Or is it just sort of, you've been smoking for X amount of time and damage is done? Right.
I mean, I think that's an excellent question. So just to clarify, it's not that smoking puts you at an 80% risk of having getting lung cancer. 80% of lung cancers diagnosed are associated with
Okay.
Smoking. So it's a little bit different. It's never too late to quit. So whether you've been a heavy smoker for 30 years or a light smoker for 1 year, smoking is always a good idea. I always tell my patients that come into the office that the #1 thing they really can do to live a longer, healthier life in the grand scheme of everything, if they're a smoker, is to stop smoking. Forget about exercising, healthy diet. It's really the smoking cessation that's important. And the impact that smoking cessation has on their risk of lung cancer really depends on their previous exposure, right? How long they were smoking. But I think the more important thing to know is that it decreases your risk of getting lung cancer, and it also decreases your risk of other conditions that are associated with smoking, like coronary artery disease, stroke risk. So always, obviously, recommended. Throughout the Robert Wood Johnson Barnabas Health System, we have several smoking cessation programs.
Mhm.
There are formal programs with a smoking cessation counselor to help people quit smoking. So obviously there are some individuals that are able to, go cold turkey and do it on their
Mhm.
own. That's really very hard. The rate of, recidivism or going back to smoking is really
Mhm.
pretty high, but with these formal programs, that rate decreases significantly. And the individuals that are part of these programs have the ability to prescribe nicotine replacement,
Mhm.
medications that can aid in smoking cessation like Chantix, et cetera. So I think that being part of a formal program can really only help in patients that are interested and have the time.
Mhm. And I think anytime you're trying to make any kind of lifestyle change, whether it be quitting smoking or even just, starting like, I don't know, walking every day, it's always nice to have support and have other people who are sort of doing it with you to help make that more of like a permanent change than just something you take on for a little while and then sort of teeter off.
Exactly. No, I agree. And I think the other question you asked me was about the signs and symptoms
Mhm.
of lung cancer. So unfortunately, there really aren't any pathognomonic or
Mhm.
signs and symptoms that are specific to lung cancer, particularly at the earlier stages when we really can make a difference in survival. So small nodules are essentially asymptomatic.
Mhm.
In the sort of later stages, or depending on where the nodule is, some symptoms can include, coughing, shortness of breath,
Mhm.
blood, unexplained weight loss. Those are really the major ones that we see. But once again, these are more common at more advanced stages
Mhm.
versus the earlier stages where, we really have more treatment options and can make an impact on survival.
So it seems like having those conversations with your provider, whether it's at like your annual visits or whatnot, but talking about, if you are or were a smoker, or, if you mentioned, I think it was asbestos, right? If you worked in an environment where it was, you were around those sorts of things, making sure that they're aware of that higher level of risk factor. So potentially you can be diagnosed early on.
Yeah, and I think, a lung cancer screening has become more and more popular as
Mhm.
the last, 10, 15 years, even though it's been recommended for much longer than that. But the United States Task Force, Preventative Task Force, actually
Mhm.
revise their indications for lung cancer screening
Mhm.
so that more people can be included. And really the important thing about those guidelines is that insurance companies will cover these CAT scans.
Yes.
So lung cancer screening is essentially made up of one low dose meaning the radiation, low
Mhm.
dose CAT scan of the chest
Mhm.
annually. The eligibility criteria is, so the current is individuals who are 50 to 80 years old,
Mhm.
have a 20 pack year smoking history, meaning that 1 pack per day for 20 years.
Mhm.
And they either are actively smoking or they quit within the last 15 years. So to your point, that I think speaking to your primary care provider about whether or not you are eligible for a low dose
Mhm.
CT is really important because, one of the things regarding, we were supposed to talk about survival rates for lung cancer.
Mhm.
So in the early stages, stage 1 lung cancer, where it's just, a mass in the lung, it hasn't spread anywhere else,
Mhm.
upwards of 90%.
Oh, wow.
Yeah, so in really early stages, okay.
Yeah.
Once the cancer, for example, gains the ability to leave the lung and go to the nearby lymph nodes,
Mhm.
survival rate is much, much lower. It's like 30 to 40%. So if we can catch these cancers early, it really makes a significant difference. So I do encourage all patients. I know that, smoking sometimes has a negative connotation and people are
Mhm.
embarrassed or they're worried or, they have fears for whatever reason, but I think at least having a conversation with their primary care doctor, their pulmonologist, whoever they seek medical care,
Mhm.
I think is really important. It can make a significant difference in their life.
Excellent. Yeah, and I know we've been talking a little bit about, risk factors, things leading up to either, having a diagnosis or thinking you might have a diagnosis. But once you have that diagnosis, Dr. Lackey, what are some of the advanced treatment options patients have in terms of surgical options? Or if you'd like medicinal options, other medicinal options as well.
Sure, and I'll talk about, I think, three main things. The first one being the surgeries that we do.
Mhm,
On one hand, the surgery we do hasn't changed since the 1960s. If you have a lung cancer, we take out the lobe or that kind of regional part of the lung.
mhm,
The way that we do that has changed markedly, especially in the last 10 to 15 years. The kind of classic approach is what's called a thoracotomy. It is the reason that patients sometimes really don't want to go see a thoracic surgeon is because thoracotomies hurt and they've had relatives that have had them. But we really actually do very few thoracotomies these days. So just to be clear, the thoracotomy is the big incision in the back where you spread the
mhm.
ribs open. Anybody on the Zoom here who's a fan of Breaking Bad or remember that they had a nice
Yes.
shot of Walter White's thoracotomy in the shower on one of the episodes. But
Mhm,
it is, or I would like to say was a very painful procedure for patients. In the current era, about 20 years ago, they started really developing the concept of minimally invasive thoracic surgery. So the initial iteration of that was using a operative telescope, so a camera on a stick, and small incisions working kind of between the ribs without spreading them
mhm,
to accomplish the exact same operation. More recently, I think thoracic surgery is one of the fields that the Da Vinci robot has helped significantly, and in
mhm,
particular, the visualization of the very important structures we have to dissect around. It's important to remember the lungs are attached directly to the heart, so you need to be very careful with those blood vessels and the structures, but the robot allows us to see those in real-time, high-definition 3D visualization, and the movements with the robot are very finesse. So we've been able to move to the point that we can do essentially the same cancer operation through much smaller incisions without spreading the ribs and causing much, much less pain to the patient. And both of those techniques, the camera on the stick and the robotic technique, have both been validated to not have any sacrifice in the cancer related principles, the
mhm,
recurrence rates, the dissection of the lymph nodes, those kind of things, compared to the old fashioned, quote unquote, standard of care. A side note on that is that what I said a little bit earlier is not entirely true. I said that we do lobectomies for cancer, but one of the things that is still the standard of care and the thing we do the most of. But we've also started looking to see if, not necessarily every patient deserves the same operation, right? So why are
mhm,
we taking out an entire lobe of the lung for both a 5 centimeter tumor and an 8 millimeter tumor, right? That's technically the standard of care. But one of
mhm,
the things we now have some data, some literature on from looking at patients is that you don't necessarily need to do a full lobectomy for every patient. And so that allows us to take patients to the operating room to get that surgical intervention to take the cancer out and do the full dissection of the lymph nodes. And we end up only taking out a segment of the lung, for
mhm,
example. Now, that's, again, not every patient. That's not the standard of care for every lung cancer.
mhm.
But for the smaller cancers that have, no concerning features, that's something that we employ. It's been very well tested and validated to be an appropriate thing to do. There are two things that are kind of surgery adjacent that I think are important to talk about. One is that the way that we treat pain for our patients has changed significantly even in the last 5 or 6 years. So we have developed not just, we've had morphine for a long time, and that was a standard post-operative thing for all kinds of operations. But in the current era, we have not just narcotics, but also new types of anti-inflammatories. We have local anesthetic that we can inject around the incisions that last for 3 whole days as opposed to 6 hours. We have
Mhm,
techniques to put pain catheters around the ribs without having to do a classic epidural around the spine.
mhm,
We can do rib blocks under ultrasound guidance. We use all those things for patients to make sure that when we're done with their surgery, they didn't just get a good cancer surgery, they're also comfortable, happy, breathing well, and can get back home and back to their life as soon as possible. Um, the last thing that I think is very fascinating, you have a couple of surgeons and a pulmonologist on here, but it's also important to realize that they're also medical oncologists, radiation oncologists,
mhm,
prehab, rehab people, all kinds of folks participate in the care of lung cancer patients. And one of the things that's coming down the pipeline that I think is very interesting for the medical oncology side of things, up until the 1980s, you either got surgery or you didn't, right?
mhm,
After the 1980s, you might get surgery, and then we had some chemo that we could give you that make you feel really bad and your hair would fall out. In the past 10 to 15 years, we now have developed these targeted therapies, things like Opdivo, Tarceva, crizotinib. These are all the
mhm,
fancy names of things that actually target the proteins and genes in the tumor cells that don't have all those side effects. And so the point being that, in the past, when you as a surgeon were looking at a patient who either is coming to you after a bad experience with chemo, or you did an operation that had to send the patient for chemo and you knew they were going to do poorly because now it's a big surgery and it's a big chemo, we're seeing tremendous response rates in these tumors with drugs that don't make you feel that bad. That can either, I think, really set the patients up well for the surgery we're going to give them, or in patients that we've operated on and the tumor has some kind of concerning feature, it's a way to treat them without making them very sick in the patients that meet the criteria for those drugs.
So I'm hearing a lot of positive things from this conversation. I do agree. I think that anytime you hear about doing surgery on the lungs, like there's like, I think everyone sort of winces a little bit at the thought of that. So it's very exciting to hear that we can do that more minimally invasive without sacrificing outcomes. And I also is very interested in these, the non-chemo therapies where, again, you're not having this horrific effect from the medication where you just feel terrible and you're getting better, I suppose, but you don't necessarily like feel that physical, like, oh, I'm getting better, which is, I think, what a lot of people want, even with like a cold, you go and you take a cold medication. If it makes you feel worse, it doesn't really feel like it's working for you, even if it might be helping reduce, the length of your cold or whatnot. So I think that if you're someone who is concerned about your potential risk for lung cancer, that should make you feel better about the treatment options out there that are available, that A, they're going to be effective, but B, you're also going to have, a much different experience than someone 20, 30 years ago who had the same diagnosis, and it's moving in a really, really positive way. So thank you for sharing all of that, Dr. Lackey. Dr. Patel, our pulmonologist on here today. How are you?
I'm good. How are you?
Excellent. So let's talk a little bit about interventional pulmonology and the lung node program that you work with at RWJBarnabas.
Sure. So we have basically 3 programs at Cooperman right now in Livingston. We have the lung cancer screening program, which Dr. Sesti spoke about earlier. That's based on the guidelines of 20-pack year smoking history between ages of 50 and 80, and active smokers are quit within 15 years. That's one program. We have another study, actually. It's part of a research grant we have called the ILCAP study, in which we don't even go through the insurance. We have a grant. The patient comes in, and if they are active smokers, we have a tobacco cessation program attached to it. So they get the counseling and whatever needs they might have in terms of medications or whatnot. And we try to follow them through and make sure, because the most important risk factors, as Dr. Sesti said, is smoking. So the more earlier we can stop it, the better outcomes we might have. And along with that, we do the screening part and we start doing the CAT scans with them. Sometimes one of the barriers which were felt early on when the screening trials were started was insurance might cover it, might not cover it. You might end up paying the bill per se. So that's why the study takes that out of the equation. The monetary part, the cost is absorbed by the study part. So nobody has to pay upfront and they're not worried about that. So, and since they do that, we get them to quit smoking, and then we can go ahead with screening going forward with that. On top of that, we have another unique program called the Incidental Lung Nodule Program, in which we have a software called EON, which goes through all the reports and any kind of scans which are done in our institution per se. It goes to the reports and sees if a spot was detected. So let's say you come to the hospital or to the ER for belly aches per se, you need to get a CAT scan of the belly to find out if you have appendicitis or not, and they found a small nodule. Sometimes things can get missed because now you're focusing on the appendix or your belly ache per se, and if you miss out on a pulmonary nodule, which might be early stage cancer, we don't want that to happen. So we have been looking into it, and we have started the program, and we have detected quite a few cancers, to tell you the truth. Mind you, these are people who are not having any symptoms. We are not looking for lung cancers or any kind of cancer per se. Our numbers were pretty staggering. We found about 22 to 23 cancers in a year on that, and that's pretty impressive. But so we have these 3 programs per se. That's what we have right now at Cooperman Barnabas, in tandem with each other. And depending on what we find, we work with our thoracic colleagues as well as oncology and radiation oncology to figure out how to go from there in the best possible way. Talking about interventional pulmonary, basically we complement each other in that regard. It's a minimally invasive, as Dr. Lackey was saying, that's the next frontier in that regards. We try to perform biopsies in minimally invasive manners per se, as well as there are oncology and non-oncology uses of it. like you can do debulking. Sometimes if the tumor is growing in such a way that it's blocking one of the breathing tubes, it's pretty symptomatic for the patient with the inability to breathe per se. So there are ways and means in which we can try to open it up in terms of putting a stent in or taking out part of the tumor from that area. And we work together as a team person, try to get it along, and that they can tolerate the radiation or chemotherapies or whatever they need to do. That's mainly the oncology part of it. There is a non-oncology piece per se, which we can talk about at some other day, if at all. But that's kind of what the interventional pulmonary is about. It's usually as in a complement, as I said. So sometimes we even help out our thoracic surgeons in terms of tattooing, because as Dr. Lackey said, the surgery is different if it's an 8mm nodule versus a 5 centimeter. So when they do it with smaller incisions, sometimes they might have a tough time finding that nodule. So we can go in and try to put like a dye or a tattoo in it, which appears really well when they're doing the robotic surgeries. It appears pretty bright, and they can take out the correct part of the lung per se in that regard. So it's like a team effort, and that's how we play it kind of.
I think that's always something good to hear, especially when you're dealing with cancers and larger diagnoses, is that there's like a team behind you. It's not just sort of one person telling you what they think and going about it by themselves, but having all of these various expertise working in tandem with each other. I know we talked at length about how quitting smoking will definitely improve your health overall, also reduce your risk for lung cancer. But are there any final thoughts any of you have for anyone viewing this in terms of if they're concerned about their risk factors or their history, or they have a lung cancer diagnosis and they're feeling, really uncertain about where to proceed or how to proceed? Just any final thoughts at all, really?
I would say that the outlook on lung cancer diagnosis and treatment is really positive. The amount of technological innovation that has come about in the last 20 years is really astounding. Dr. Lackey mentioned some of that regarding, the Da Vinci robotic platform and how we can do these technically very complex operations through, 4 1-centimeter incisions without compromising any of the oncologic part of the operation. Also in the diagnosis of the lung cancer, not just the treatment, but the diagnostic part of it is really come along. So we do have several systems. Dr. Patel and Dr. Lackey and I all use these systems, essentially allowing us to navigate from the inside to the nodule to do a needle biopsy to confirm whether there is a cancer or not. The newest modality of that is the robotic bronchoscopy system. So it's actually a bronchoscope, which is mounted on these robotic arms. It's almost like out of a sci-fi movie. It's really very impressive. It allows us to do these biopsies in a technically very precise manner. Those are all technologies that are available through multiple hospitals in our system, specifically at Barnabas Medical Center. And then, I think Dr. Lackey did a very nice job in reviewing all the treatment options. So the 3 major treatment modalities that we use to treat lung cancer are surgery, radiation, and chemotherapy / immunotherapy, which is the targeted type of chemotherapy. And depending on what kind of lung cancer the patient has and the stage will determine which one of these treatments. Sometimes it's one, sometimes it's all 3. But there are so many more options now that are available to patients with lung cancer, so that I think the fear of, well, if I get diagnosed with lung cancer, it's a death sentence. I really think that that's a little bit in the past, because there are just so many more options now that are available. And even in patients that have metastatic lung cancer, where it's, spread to the brain or the bone or outside, the chest cavity, prior to just a couple of years ago, this was in fact a death sentence. But with some of these newer targeted therapies, the patients can have really dramatic results. So I think the fear of getting diagnosed with lung cancer obviously will always be there, but hopefully it's mitigated some by our ability to diagnose them in minimally invasive ways, treat them in minimally invasive ways, and also treat them with newer agents that have really dramatic results.
Excellent. I think that's such a positive note too, because like you said, I think there is like this, and I think any type of cancer diagnosis, there is that initial fear, right? When you're sitting in the office and you're getting those results. But being able to sort of couple that diagnosis with, yes, you know, you do have lung cancer, but here are all of the treatment options and the ways in which you know, it's not just going to treat it, but it's going to treat it in a way where, you know, you're not in a lot of pain. You're not having necessarily all the same physical symptoms from the treatment as you were, as Dr. Lackey was saying, 10, 20, 30 years ago. I'm sure really helps reduce that anxiety and that stress in that initial sort of visit when it all sort of, you know, I'm sure there's a level of surprise, obviously, even if you're sort of expecting it.
Yeah, and honestly, my hope for Lung Cancer Awareness Month, and not just in 2022, but in the years to come, that lung cancer screening really becomes just like colon cancer screening, breast cancer screening, right? Where it's just, if you're a candidate, you go and you do it. And there isn't a lot of just like fear and anxiety about it. I feel like there is for lung than perhaps some of the other sites that we routinely screen for, and nobody bats an eye.
Yes, absolutely. Dr. Lackey, Dr. Patel, anything to add before we wrap up this afternoon?
No, I think we've talked about a lot of interesting new stuff that sounds really good, but I just want to emphasize, I think both Dr. Patel and Dr. Sesti just touched on this as well. The two take homes from this, you know, aside from all the fancy stuff we talked about, if you're smoking, try and stop. We have ways to help you do that. And if you meet lung cancer screening guidelines, get screened.
Excellent.
I just wanted to add one thing per se. So as Dr. Sesti said, nobody thinks twice about getting a mammogram or a colonoscopy or something like that. So in medical terms per se, we use something called number needed to screen, meaning how many patients you need to screen before you get one cancer diagnosis or to save a life per se. In mammograms, like between ages of 50 to 60, you need to do about 1,300 mammograms before which you will save one life. And flexible like colonoscopies or sigmoidoscopies, it's about 800. You only need to do like 100 lung cancer screenings to save one life.
Oh, wow.
130. So it's a big discrepancy and people don't realize that. So it's very important even to talk to your physician. If you have any questions, meet with them. Everybody, like it's a pretty big number. We only screen about 3 to 5% of the eligible population. It's very dismissal, right? If you think about it, because usually there's a social, like a stigma attached to it. Oh, I was a smoker, that's why I got it. But it's not like that. There's always hope for everyone. Now with the new therapies, per se, it's become a chronic illness and not a death sentence, as Dr. Sesti and Dr. Lackey said. So.
Excellent. So I really like ending on that note. You know, find the support that you need. You know, like everyone said, we do have programs here at RWJBarnabas to help you quit smoking and get that support, and you know, speak to your provider about getting that screening. Yep. So I thank you all for joining me today and taking some time to talk about lung cancer, and thank you to everyone who's joined us on the live or who might be watching the replay. And I hope everyone has a great afternoon.
Thank you.
Thank you.